I'm really excited today because I'm going to be involved with Secretary Hazel again. This man keeps you going, let me tell you. So it's my honor. I get to introduce him. I'm going to tell you a little bit about him in case you don't know. Dr. William A. Hazel Jr. is serving his second term as Secretary of Health and Human Resources for the Commonwealth of Virginia, a post he took up in January 2010. As Secretary, Dr. Hazel oversees 11 state agencies with more than 16,000 employees. I don't know how you do that. Covering such diverse programs as Medicaid, behavioral health, social services, and aging and rehabilitation. These combined agencies spend approximately 1/3 of Virginia's budget. During his first term as Secretary, he led the Virginia Health Reform Initiative, helped establish the Virginia Center for Health Innovation, and served as the founding chair of Connect Virginia, Virginia's Health Information Exchange. He is also co-chair of the Governor's Task Force on Improving Mental Health Services and Crisis Response with the Secretary of Public Safety and the Lieutenant Governor, and co-chairs the Governor's Task Force on Prescription Drug and Heroin Abuse with the Secretary of Public Safety. Prior to his appointment as Secretary of Health and Human Services, Dr. Hazel spent 22 years as an orthopedic surgeon in Herndon, Virginia, which I appreciate since I had a hip replacement. You guys are important. His professional experience includes...
I didn't do it, though. How's it working out for you, Mary?
Well, his professional experience includes working as a team physician for the Chantilly High School Chargers, serving as an assistant orthopedist for the Washington Redskins football team. I'd like to hear some of those stories. And serving as team physician for the DC United soccer team. Dr. Hazel lives with his wife Cindy in Oakton, Virginia. I gather that's when you're not spending all your time in Richmond and going all over Virginia. They have 2 grandchildren and 2 very cute granddaughters. Please welcome Secretary Hazel.
Thank you, Mary. If you all can hear me, I'm going to try to stand over here so I can see what they told me to say. The way it works, normally you come with the Secretary, you got a deputy with you. When I'm finished, they'll tell you what I meant to say, but I do mean to say thank you to Mary, though. She's been a great friend and supporter the last couple of years with the State Executive Council, and has been in and out of Richmond and other places for a lot of things. We appreciate the connectivity, so she's been hustling for you, I can tell you that. So, asked me to talk a little bit about hot topics, and I think the ones I'm going to speak about primarily today will be some behavioral health, a little bit about opioids. You have some CSA questions, and I've got a list of things here that I'll get to at the end. But one of the, I don't know whether it's an advantage or disadvantage, I'm now completing my 8th year as Secretary. I got about 2 months to go, and we're in transition, so we don't know what's going to happen. But Secretary years are a little like dog years. So 7/8 are 56, which means I'm older than you, Lee. I mean, I really am. So you picked up a lot of experience, and I define experience as what I've got right after I needed it. So I have a lot of experience. I'm going to share a little bit of that with you as I go. And the first thing I want to mention, and some of you have heard this before, we talk a lot about silos. And we think things are vertical, right? This is the farm where I grew up. This was a couple hundred yards from the house I grew up in. And we think about the verticals. And now, of course, in the holy city of Richmond, we refer to them as our cylinders of excellence. But that's a different problem. But you've got this, but the truth is silos can be horizontal too. And the challenge that we have collectively as we try to do the work is that we've got federal, we've got state, and we've got local. And when things aren't lined up and aligned and we aren't communicating, it doesn't work very well. I tell people all the time, secretaries really don't do anything. We take credit and blame for things that happen elsewhere, and where the work is done is locally. And I'm going to come back later in the presentation and show you why it's so important to recognize local variation, but it matters in how we organize ourselves. And this is what I've done. So I came in as secretary in 2010 out of practice in orthopedic surgery. And my colleagues in medicine asked me at the last minute site junior meeting, what did you learn? And I knew a lot about policy, but in health, it was all like this. And when you start thinking about the problems that we have, your vision expands. And so, you know, you're getting a broader look at things, but it is not just about health, and it's not just about Medicaid, it's not just about behavioral health, it's not just about social service and children's services and things like that. It's about whether our people are doing well. And I think what I've come to learn a little bit is that what we need from society, particularly what we're seeing recently, when we get to the addiction things later, it's about opportunity and hope in life. And I think we're missing. 100 years ago, anybody know what happened in 1917, 100 years ago? Historic event. The lady you were telling me about, you were there, weren't you? The Bolshevik Revolution? What happened there? In the whole story, it's 100 years ago, the czars were overthrown and the Soviet Union started in its infancy. And more people have been killed as a result of that than almost anything else that's ever happened. What caused that? A society where people didn't have a chance. And we saw it all through the 20th century. You saw it in China, in Southeast Asia. Some would say a lot with Germany in World War II will lead up where people didn't have a chance. It's not that the outcomes are always going to be the same, but I think we're seeing some of that in our society now. So we've tried over time to really think about the human resources differently and not in the agencies. And the reason I say that is when you go back to that agency thing, a child in your community that's in trouble, and all of you have a lot of them, children live in families, they don't live in social service agencies. And social service has your eligibility, your SNAP, your TANF, your Medicaid, and so forth, and they have child support enforcement and all that. But if you're in a family that's got trouble, there's a chance that they're going to be involved with the CSB, and there's a chance they're going to be involved with the health department. And they don't live in our silos. They don't live in our funding streams. And so if there's no perfect structure, the things we have to think about, and on the ground where you are, is different than the state, because we can have information all over the place that we can't share with each other by state law, and it still comes down with one or two people. You know, Sheriff Leonard's in the back, and he's been a great partner. Hell, he's in public safety at the state, but what do we do in human services without law enforcement? Because most of the, I won't say most of the time, much of the time, the first interaction our people who are struggling with have with us is through law enforcement. And if we're not talking and sharing, it makes a difference. Now I'm going to show you a quick example here of where programs don't line up. And you see this on the ground. This is, we call this the road to self-sufficiency. And it's not really. But if you're a single mom in Richmond, the day you come into the quote, TANF, the welfare program, you got disposable income. Now this assumes that she has a Section 8 housing voucher in probably about 8 programs: Medicaid, SNAP, TANF, the kids are in WIC, they're in school, free and reduced lunches, all of those things. And guess what? They're all separate programs. And who's doing the eligibility for those? You all are. Your social service agencies and your schools are doing it. You're paying for that, and it's all done repeatedly. It's going to be a repeated theme that I come through today. But as we tell her to make money, and she's got to make money, she's got 2 years, right? As soon as she earns money, she starts losing benefits. She loses her TANF here, she loses her SNAP here, she loses her child care here, and suddenly she's at about $12 or what, $15 an hour, and she's in the hole, and she's got to be at $53,000 before she breaks even again. Now, would you design something to work that way if you really want people to be successful coming off of our programs? But that's what we are trying to deal with. And Washington sends us a lot of these roles, and we add some of them. And so this is just important to realize when we talk about barriers and why people get hung on the programs. This is, I think, one of the major causes. It's not everything, but it is a huge piece. And I don't know that our politicians in Washington understand this when they go up. They fuss about who's doing what and so forth, but they're not getting to the problem solving as I see it. Now I'm going to put in one comment here. Some of the reason this doesn't happen is because our silos don't talk to each other well enough. And the numbers don't run across as they should. Do you know Jim Reginbald speaking upstairs, which is where a lot of people probably are, but 2 years ago I did a little study. We spend $1.7 billion on kids 0 to 5. Can any of you all say in your locality how much you spend on kids 0 to 5? I mean, can you? But you can probably look at something or get it from us and know what you're spending on social services and this and that and the other. But when you look at that, you're asking yourself, what is my program doing? And when you get the big numbers, say 1.7 billion on kids 0 to 5, well, what are we getting for that? And to me, that was kind of one of those experiential moments that I talked about. I think the guy in the other room called it a teachable moment. Because if we continue to look at things vertically and not look across, we're missing the point. And I'm going to come back to this again. This is an example we did just in 7 programs in social service, 2.66 million people if you took them all individually. But you know what? 35% are in 2 programs and 10% are in 3 programs. Now the people that we are spending our money on and you're using your resources on, the law enforcement, social service, and CSBs are all chasing around, you know what? They got more than that. And we have no ability, because of data sharing restrictions, to actually know who they are and know how to put them in their context, because they have to exist in a family or some sort of social structure, or they will fail, and Carl Leonard back there will take them back in jail because it's the only way they can get help. And that's temporary. So there is a state law, it goes back to 1976 on our end, that says data can only be used for the purpose for which it was collected. And then with us, we've got 344 pages of exceptions to that. You have had 15 of your localities have had a work group since January looking at data sharing issues. A common complaint in Northern Virginia, where you've got millions of people changing jurisdictions every day during the course of the normal flow. Arlington police pick someone up with substance issues, takes them to jail. No idea that in Loudon they're already in the system and known. And we have no way. We've got to turn that around, and that involves sharing what we do now. The medical term for what we do now is stupid. Just So I'll tell you, this is another example. We have created the Children's Cabinet. I'm going to come back to that, but we have these 4 secretariats: Health and Human Resource, Education, Commerce and Trade, Public Safety, and Homeland Security. 4 secretariats, 17 agencies, 151 funding streams, spent $6.35 billion of taxpayer money, excluding what we're doing, spending on teaching kids in the classroom for 0 to 21. 0 to 21, $6.35 billion, excluding the actual pedagogy. And they're all a bunch of programs. They're the big rocks we just pile down, the federal money, and they aren't connected. And we depend on you to do that at the community level, because we're not doing it. And we've got to do better at that. And we need you to stand up and say, you can't keep handing us this pile of crap and all these rules with these different programs that aren't lined up. One telling us one thing. Has you all experienced this? One of the agencies telling you one thing and the other agency telling you the other thing. And it's the way, what I tell the journalists, we're not doing it right. We look at things by these numbers, and that's really runs us, and not the program and the results. So I bring that out mainly as you're beginning to share a little bit of experience, but we spent a lot of time, and this is one thing I do worry will get lost going forward, the ability to share, to align. We use the principles of what we call collective impact. Set a goal. You've got a population. What is the goal of kids, of that $1.7 billion we spend on kids 0 to 5? What would you all consider a goal? Maybe ready to go to school and learn. That would be what you all are paying for, right? When you want them to learn in school, and when they don't learn, we pay for that. By the way, if I say who pays, think of it as the call and response part of the sermon, and I say who pays, you all say we all do? Okay, so who pays for it? When we pay, we all do, right? So getting that working together is important. So we've put together the Children's Cabinet, and are trying, and we share information, but you've set a goal. What do you want? A measure of success. What does success look like? How well are we doing to get to the success? Then people can choose their what they want to do around that, but we got to all agree we're doing the same thing, and we're trying to create the infrastructure in terms of information sharing and so forth. There's no perfect structure, so it's really the culture of how we share, align, and work together that matters. And the same thing has to work with state and local too. I mean, it's the horizontal that everybody seems to overlook. And there's a professor up at Harvard who talks, this is actually Albert Einstein, but a professor at Harvard talks about adaptive thinking versus technical leadership. Technical leadership is, this is a bad guy, lock him up. That was a technical solution from 20 years ago. And Carl, how's that working out for you? You all know Carl Leonard, the sheriff in Chesterfield back here. How's that working out for you, Carl?
Hasn't worked out too well.
It's not working out real well. So what do you do? And what do you do when we don't know the solutions? And the guy that I listened to do this lecture a couple years ago says, people who don't want to even see each other have got to sit in a room and talk it out. And I think that's the biggest thing we have to do. And what I've seen in my 8 years is, we're not as bad in Virginia some places, but it's good because but the pointing fingers. Ms. Pemberton, I'm glad you could make it. You're late.
Thank you, Dr. I know that.
You did that on purpose, didn't you, Your Majesty?
No, sir.
So, we've got to get a little past that because we're not going to solve the problems. But let's talk about behavioral health. That is a problem, and that's a big one we have. We spend an enormous amount of money on behavioral health, $1.3 billion mental health from the state level in 2016. This is, I don't believe, including your local share of spending for CSBs and so forth, which is variable. But what people may forget is that $770 million of that is Medicaid funded, $336 is state mental health, and then we have the CSBs, a big bucket of money. And the challenge is, Carl, none of that is going to, what is the largest mental health provider in Chesterfield?
Jail.
Your jail. Yeah. So we have a wrong pocket problem. You all say, well, Secretary, we can't put more money in here because we don't have the money. And if we save you any money, it's going to be in Carl's budget, and Carl's budget goes down. He says, now I can't afford deputies. What do I do? We have a wrong pocket problem that we'll only solve by looking not at the silos, by looking across what we're getting and reallocating, I think. And that's something that I would say is really important. A challenge we have nationally, 23% of money spent on institutional facilities and so forth for behavioral health. In Virginia, where we are at 46%, double the national average of people put in institutions. And you can see that the money is that we spend on it in community service is very low. And that leads to a problem we have, and I'll get to that in just one second, but we talk about who here thinks healthcare costs too much? Go ahead and put your hand up, right? We all do, yeah, thank you. And who pays for that?
We all do.
Yeah. So, but what people are we're missing, and I think the medicine lost the brain a long time ago. We think about the physical things, but if you look at here, chronic diseases, hypertension, diabetes, coronary artery disease, all these things, significant increase in incidence when people have mental illness or substance abuse or both. And then, whoops, wrong one, let me turn it back on. And look at the cost you see when you have, this is with mental illness and drug and alcohol up here, this is hypertension. Look at, this is basically $10,000 a year more. This is more, you see what you have right here? And we're not taking that into account because we have silos in healthcare. We have separated physical medicine from mental health, and it's not working out for us very well. And so what we're really working to get those is integrated. And the real challenge is we put together a system of pieces. We've got the Medicaid program, we've got the CSBs, we've got private providers, we've got state hospitals, and whatever else fills in at our jails and corrections. And it's not working for us particularly well right now. So what we're really trying to do is create some alignment. It first starts with what is the outcome. We put in some new measures for mental health at jails that we're trying to get some consistency across. And it's work and it's changed for everybody, but this is inconsistent. One of my pet peeves is, well, you'll send somebody to us at Western State Hospital, that would be Fairfax or Prince William to Western State Hospital, and we stabilize you and put you on medication, and then we send them back, and guess what happens? You throw the medicine away because it's not on your formulary. Now, why did we even bother? Why did we even bother? And so what we proposed, well, let's have a common statewide formula. You know what I hear? We can't do that. Well, we have to look beyond our little focus, and those are things we've got to get. State hospital admissions are a problem for us and for you. We've managed to get the jail waiting list down. We have anybody over 7 days right now waiting to get into a state hospital, but our problem is our occupancy is very, very high in these the increases since 2013. When you're running above 85% occupancy of a state hospital, it is unsafe. And we're 98, sometimes 103%. I mean, we're really up there. And that in turn, these are the admissions and discharges. I think we admit about 71 or 2 people a day through our TDO process. Did you know that? We're doing 260 evaluations a day, your CSBs are, and we're admitting 70-some people a day now. And we haven't had a failed admission due to lack of facilities since the last resort legislation went in, not one. We're doing it. And in the process, it's killing us at the hospital level. We can't keep staff. Our turnover rates are high. We have vacancy rates. So one of the issues we'll be looking at in the General Assembly this year is actually trying to get staff salaries up around the hospitals, because when you have high throughput, it's a lot more work. And then we have, and it's expensive, and we've run the numbers looking if we keep going like we are, the money just goes up, and we're going to need more and more beds, and that's not sustainable for us. So why I'm telling you all of this is one of the discussions we've talked about is realignment of how we pay for mental health. What happens when you send us a patient and they're in our facility, we pay for them 100%. When we send them back to you for community-based services, you pay for them with whatever state funding. So what's happens is that leaves us right now in a situation where on a given day, this was the end of August, we've got anywhere between 170 and 200 people in the state hospital that should not be there medically, but have no place to go. So we've got to figure a way to align our interests so that you all benefit and can afford to have the community capacity, which is where these folks need to be, and we can get the beds back. If we build more beds with that money, they will fill up, and then this problem will be worse. Now, I don't think it'll happen this year. I'm pretty sure we've backed off of it for this year because we don't think the CSBs are ready, but it's going to take a level of understanding and management sophistication to figure out how the money needs to flow through this. But I don't see any choice but to create that alignment. So we all got to be playing on the same team here. And even well-intentioned folks, if I don't have any money and I've got all these things I can do, they can't solve our problems under those circumstances. So we need to figure that out a little bit. You've heard of STEP Virginia, possibly. That's the System Transformation for Excellence and something, I forget, I don't like the term, but that's what we got. But we have moved towards creating same-day access in the mental health system. And a number, I think 23 of the CSBs actually got some funding for this, and we will put that in. General Assembly has told us we will do this, so that will go into the budget going forward to get this more. But the idea is that if today is the day I decide that I'm not going to take this drug anymore, and I come to see you, and you say I can't see you, there's a chance, by the chance that appointment opens up, that I'm dead. And that's as simple as that. Or the frustration, so we've got to get the same-day access right, and we have to have the services there in the community. So we are working with your community services boards to try to work through all of these. And I won't read the slide to you, but what we're looking for in this is a complete list of services that can be available. CSB doesn't have to provide them necessarily, but they have to be available in order to take care of the folks that we're seeing. And I refer to this as sort of the deep end public system, because what's really interesting, I'll go there, is we've got to get that fixed. Got my slides out of order. We've got to fix that CSB deep end system, but we have to align this with Medicaid. I showed you that earlier slide. Medicaid has most of the funding, and most of the people don't get to the deep end systems, but they can't operate separately. We have to be able to have people moving in and out. So we're spending a lot of time as we look at Medicaid designing the alignment in the system so we're all speaking the same language. And Medicaid pays for all these behavioral health services. And I'm going to come back to the expansion question in a minute with regards to this, because all of this is going to take resources somehow over time. And so we pay for these services, and we are moving we are moving towards more coordinated care. Fee-for-service has been the way Medicaid was done traditionally, the way Medicare is done. Our Medicaid director calls fee-for-service FFS, fend for self. And what we're doing, and when you have mental illness and addiction issues, or you're older with dementia, it's really hard to do. So we're putting the case management in the plans. Medallion 3.0 is the insurance program that we currently have for basic health insurance, and Kim from Aetna's back here, they participate in that with us. But you know, we do have behavioral health home pilots. The idea is that if you are mentally ill, maybe your family doctor can't manage that, so we build the medical home around the mental health care, and we pay for it accordingly. So it's a different way of paying for things than just paying the doctor, because if you need a mental health home, you may need physician care, but you may need nurse care, you may need peer counseling, which is very effective. You may need other types of supports that just doctors don't do. And you don't want them to do because you need them focused on certain things, so we have to pay differently to build these teams. We've done the same thing with the Commonwealth Coordinated Care, which we're rolling out now. That's the age blind and disabled. It started in the Tidewater area, I think in August, and we're rolling out that, moving all of this to some managed structural program as we go through Medicaid. So I've suckered you into a hearing a little bit about Medicaid too while we're talking about this. And we are really trying to create, sort of fill the gaps. You know about the GAP program we put in a couple years ago. We had some money in the budget that was appropriated that we hadn't spent, so we basically said we will cover physician payments, laboratory studies, and for outpatients for behavioral health issues. And it's a limited population right now that's eligible, and one of the alternatives to Medicaid expansion is to increase the number of individuals, that can access this program. But we're trying to align it through the whole spectrum as we move through, so that at the end, you know, we've got, this is with substance abuse services, pharmacy. We want everything lined up between all of our programs, and there's been an unprecedented amount of work between behavioral health and us to get this. This is the GAP enrollment numbers that you can see here, what they're getting. Pharmacy is a big and expensive piece of this, and we've got to manage the pharmacists. My own bias will be hard for a lot of people to swallow, but if the taxpayers are paying, we should have one formulary. And whether somebody's in Carl's jail or in Mary's CSB or in our state hospital, they're getting the same medications. It's a quality of care issue. And if we bulk buy, I think we can do a better job of getting that. But we all have our own contracts, and that makes it hard to do. But we've got to get past that if we're going to start chipping away at this cost of pharmacy. We set up this last year, we introduced the Addiction Recovery Treatment Services Waiver. This, I think, is, I don't know, Kim, you may say this is probably a national leader model for treatment of people with addiction. And I do another talk for the managers later where I'm going to talk about opioids, but this is an addiction issue, folks. And opiates have our attention because we lost 1,133 Virginians last year. We've been losing for the last few years more Virginians from drug overdoses than from motor vehicle accidents and gun violence. 64,000 Americans died of overdoses last year. And you know what's really interesting? More people died from addiction to tobacco. More people died from addiction to alcohol. But it's come so slowly, it's not getting attention. The issue is addiction. The drugs are changing. They will change. They will change. And we've got to figure this out. But this program has actually pays for these services, which I will not bring to you. Yes, sir.
I've been hearing all this stuff for years and years and years. This is kind of coming to, I mean, when are we going to educate that people need to take care of themselves?
Can I come back to that in a minute?
They need to pull up their own pants and quit taking these drugs.
Anybody want to say amen?
Amen.
Amen. This is, you're preaching to the choir here. I mean, I've been there for years, but yes, there is some of this. The challenge that we have, though, is that now they're there. And what do we do with people who are addicted? Has anyone read the book Dreamland? Okay, the author, Sam Penunz, was in Richmond twice in the last month, and once you're addicted, however you got there, once you are addicted, your brain has changed. Physiologically, it is not functioning like it normally does, and you can see that on the MRI studies and these things. It does it, and he described, this is his words, you know, that it is the relentless obsession to get the product that will make life bearable. It's no longer a matter of getting high, it's making life bearable. And he actually says it's kind of like the American experience. We're all out buying stuff to make our lives better. That was it. But the issue is that once the brain has changed over, now we have people who are addicted, and there are 3 things that can happen when people are addicted. Any Woody Hayes fans here? Remember the old college football coach at Ohio State? Coach Hayes, why don't you all throw the ball? Because when you throw the ball, 3 things can happen and 2 are bad. But so when you're addicted, 3 things happen and 2 are bad. You die. It's one of them. You live with the harm, and anybody experienced or seen the increase in kids' number in foster care in your communities? Yeah, it's real, and the number percentage due to opioids has gone up. The overall number has stayed pretty much the same, but addiction is the leading cause. Anybody at the hospital had a neonatal abstinence baby? That you have, whether you know it or not. Infectious diseases, hepatitis, AIDS, endocarditis are out there. Anybody seen naloxone use in their communities pick up, and now we're dealing with multiple naloxone uses. Work productivity goes down with addiction, and then I haven't even mentioned the burden on law enforcement in our jails. Who pays for all that?
We do.
We all do, yeah. So, I mean, that's the issue. So the challenge is, and I was with Secretary Moran a couple of months ago in the room and said, what are we going to do with these people? Shoot them? And I said, well, wait a minute, you do some of that. But he didn't like that. But the point is, we can't. That's not. And so another option for these people is they die. Life expectancy for people with substance abuse is much lower. And the truth is, the same 3 things exist with mental illness. Your third option is to help them into recovery, and we need them back, so we got no choices. We can throw up our hands and say, what do we do to keep them from getting started? I will get to that more in the next talk than this one, but at this point, addiction is a chronic, recurring, or relapsing disease. It's kind of like leukemia or lymphoma, where you get it out and then maybe it comes back later, and we're going to have to address that. But this is the first step in that. And I can tell you, since we've put this in place, we've seen 50% increase in the people who are covered, able to access the service. The practitioners have gone up, and you can see those treating the problem going from 300 to 691 for opioid use disorders. And I mean, we've had, I mean, it's one of these few cases in government, I say there was a cause and effect that I think is really positive. Now, 90% of the people who benefit from this can't get it because they're not Medicaid covered. Let's skip this one. We are moving virtually all of our programs to managed care. I'll throw this up. It's not just mental health, but CCC Plus is really our adults and people with disabilities. We're moving into a more managed situation. The idea here is that just sticking them in a nursing home isn't working either. It's very expensive. It's not a good. Who here wants to be in a nursing home when you're 10 years from now? Anybody? Nobody does. But unless you change the way we pay and how you coordinate, if you're going to stay at home and you need help, it's harder to do from a management standpoint. So we're really working to make that happen. Now, if anybody does want to be in a nursing home, come speak to me later, and I've got a bed for you. Well, if there's no waiting list, I can get you taken care of today. So I have to mention where does the money come from all this, and you're going to hear, this is not political pro-con, but you are going to see Medicaid expansion in the budget again. And what that basically boils down to, if Medicaid expansion is done, even at this point, having foregone the better years of it, it's still about $139 positive to the general fund at the end of the day. Virginia makes money on that in terms of our budget. Again, it's that horizontal siloing. Feds pay, but the state budget actually picks up $139 million. If it's done with a provider assessment of some sort, it could be as much as $400 and some million back to the bottom line. But in addition to the bottom line number, we get about 200 million a year for behavioral health and another 100 million or so for substance abuse treatment, which is why it's such a big deal. Now this is to show you a couple things. This is the opioid problems we see in Virginia. This is the rate of prescription opioids. These are pills that have been prescribed inappropriately or appropriately and then diverted. But notice it's not the same all over. All right, look at Southwest versus the rest of the state. And when I was talking earlier about, we're different in different areas, these are fentanyl, heroin and fentanyl overdose rates. We got them up here in this area, but not so much down here. We have a problem in Richmond. We have to make some policies that work for the whole state, but what you all may be seeing on your end is different. The number 2 and 3 drugs are cocaine and methamphetamine that are coming to the lab, and they are not gone. In Galax, the problem is meth. I don't know if anybody, Pulaski, Andy Crawford, can be interested. This opioid stuff, we've got meth addiction, folks. That's what's driving it. A lot of the symptoms are somewhere. The drugs this is all fatal overdoses, all drug overdoses. It's more than what I said, the 1133, because there are other drugs besides opioids. There are things like Valiums, the benzodiazepines, there's cocaine, and others that are causing deaths. But we can see that the fatalities, the big thing here is that this is all opioids. And then you can see the changes in these purple lines are fentanyl. Fentanyl is the more potent form. And so as the drug supply comes in, we're getting more potent drugs. And now this fentanyl is even endangers your law enforcement officers because just brushes can overdose them if they're naive, they've not been exposed to it, which is why now you're looking at hazmat suits and labs and things like that as it's changed. And that's all an issue we're trying to get to. This stuff by the way, can be ordered online. You can get it from China, you can get it from Mexico. If we focus too much on traditional opioids, plant-based heroin, we're going to completely miss the next wave. If you imagine that you can make something in your lab or in your kitchen, like meth, but only it's fentanyl, do you think they're going to bother shipping stuff in from the Middle East or South America that's plant-based? The farmers get screwed again, but that's what we're seeing right now. So where we are with this, we have a 5-step approach to this. And number 1 is harm reduction. I mentioned all of those things before. No matter what we do, there will be people who will not want to go into treatment, and they're out there causing harm. There will be people who want to get treatment, but treatment's not available, or it's available but unaffordable. So we're going to have to deal with that. The next piece is really making recovery available. I mentioned the arts waiver. We're big fans of substance specialty courts, treatment dockets, therapeutic dockets, and so forth. Did anybody know Chip Hurley down in Tazewell? Who's the judge down there? I've been to 3 of his graduations. He's had 13 babies born drug-free out of his program. And he will tell you it costs a lot less than to put them in jail, and the outcomes are better when they go through the process. And it depends on a lot of things to make that work. So we really think that's important. I know Sheriff Leonard and I have talked. He's got a problem where he's got people. Why don't you tell him? They finish up in jail, and what do? They ask to stay.
They do. They come out the back door when they get released. They come around the front door, ring the doorbell, say, "Can I come back in jail and participate in that recovery program?"
Yeah, he has a recovery program. It's not a medicalist. Well, he does have that now, but I mean, and Mike Wade and Henrico will tell you the same thing. That they ask to stay because sobriety and treatment are not the same thing. You can be sober after a month in jail, but you are not treated because the minute you go out, the cravings are there. It's if you're a diabetic and you come into the hospital with a diabetic coma, we get you all stabilized, but we send you right back to the same environment where the cookies are there and you can't get your insulin and all this. What happens? You recycle. And by the way, who pays for that?
We all
do. Yes, sir.
I've been in recovery 22 years. And it's so much more difficult when you're out there by yourself trying to recover. Have you considered an aftercare group like
Oh, we
do.
do.
We have a peer group that have their own Facebook page, and they actually pick each other up when they come out to get released. So they do have a network now, and that is the most important thing, to change those people, places, and things.
But to say, oh, be a big boy and stop drinking, it
Doesn't work that way, does it?
doesn't work.
Yeah, that's the thing, when, you know, one of the things I've learned in this job is with addiction and even with mental illness, the peer support is good for the peer and the individual, both individuals. It is critical. So when, in fact, with our arts waiver, we have set up a way to pay for peer involvement, which I think is, we're one of the first in the country to do that. And we've even created a register. The issue is, of course, if someone, the nature of addiction is that people relapse, so we need to be sure that people are able to do the job and so forth. But thank you for speaking up. That takes some courage to do. To your point, we have to get to prevention. And that takes two forms. One is changing prescribing habits. There is no doubt that this problem is largely iatrogenic in the United States. By iatrogenic, it means people like me wrote prescriptions. We were taught, back when I started training in the 70s and 80s, you know, these drugs were dangerous, don't use them. But there really wasn't a lot of understanding of what they did and what proper dosing was and how to wean people off. There was this movement, born I think largely out of compassion, to say we're not doing a good job of taking care of pain. So these advocates, the patient advocates and so forth, came out, and this is unfortunately was sponsored in part by pharma, where it was, you know, we have to be more aggressive. Who's been to the emergency room of the hospital and seen those little smiley faces? And they ask you if you hurt and you say 6, we're not likely to send you to yoga. I mean, it's not one of our tools when we wake you up at night in the hospital. We're there to give you pain medicine. And for those who are susceptible, you end up very quickly getting habituation and then addiction. And then the other thing that happens as a consumerism plays into this is that one of the worst things that you can do is to tell a patient they can't have your medication. I was at a medical staff meeting for my hospital last Thursday night. This guy was saying, so this guy drives down from Martinsburg, West Virginia to Fairfax to see me, and he tells me exactly what drugs he wants. And you know what? I'm scared. If I say no, I mean, all these shootings that go on, think about that. And on the other hand, we have people saying, well, you know, there's this pain problem, and these folks don't have addictions, and you can't shut them off meat. So we're trying to find the nuance. So we put that into our regulations. And if we have time, we'll get back to that. But we also work with law enforcement closely on interdiction. And this data sharing problem I talked to you really matters in opioids, because if we're going to do this, law enforcement has to be able to tell our people what they're seeing, and our people need to tell them what they're seeing, and we need to do it in fairly real time. You see an uptick in overdoses someplace, and not everybody knows that we're unprepared for the people who are coming in. We're under-treating with naloxone. We aren't catching the bad guys because we aren't able to keep up. So, and that's all about data sharing. And then there's this culture change piece, and this is what you're getting at. And I think there are 3 areas that need culture change. 1, kids, legal and safe are not the same thing. The fact that grandma got it at the dentist and it's in her cabinet doesn't mean you can pass it around safely at parties on Friday night, and that happens. The second piece of culture change is pain does not require narcotics automatically. In our high-intensity drug trafficking, I remember being down in Wise a couple of years ago, and the guy who runs the HIDTA for Appalachia said, there are just too many pills out there. We chase bad guys. We don't chase doctors and nurses. We can't control this. You've got to. But part of it is, if there's a demand, there will be a supplier. And one of the challenges we have is when we're given the legal medicines at high doses, at least they know what they've got. When they go to the street, they don't. And that's when they die. So part of it is we can't just cut it off immediately, or we will see the repercussion of going to the street. But it starts with the pain management and the pills, and that's going to require culture change. Why I'm telling you all this is that isn't going to come from Richmond, folks. That's got to be done where you are. It's got to be done where you are. The third piece is the issue related to stigma and treatment. And gentlemen hit it on the head. When you come out of Carl's jail, now you are branded as both an addict and a criminal. Who wants you to live next to them? You all get those problems, don't you? And what are you going to do if you don't have a house? And of course, employment becomes another problem. So now you don't have a house and a job. Now who's paying for you? We all are, right? You can't take care of your wife and kids. It's hopeless, so what do? Go back to step one again. And it's the connectivity, I think, that you point out, the support that for some is like an everyday thing for the rest of their lives. But what are our choices here? And that's the hard part. But we've got to figure out, and the mayor of Washington County, Tennessee, talks about creating drug-free or substance-free workplaces. He says, look, I know people are using, I know they have, but if we can get people in recovery and help them stay in recovery and work, it's a win-win for us. We've got good employees who can use their work, and we're helping them with recovery. So maybe we need to think a little differently about how we manage that. But again, those are things that frankly are going to be more at your level than at the state or national. Because again, what I said earlier, we don't do anything in Richmond. I mean, I take credit and blame, is what I do. But the work is all done locally and in communities. The best community coalition we have is in the Upper Valley around Winchester. It started with the police chief, the hospital got involved, got a juvenile court judge, the CSBs, and they come in and they meet regularly. They got $30,000 seed money from Casey. Now they have a full-time coordinator. They're really making this work at a local level. It's not all easy, but that's, Roanoke's got a good program too, if any of you from here. But let me just hit through some of the highlights here for you. Reasons for removal from homes. Substance abuse, parent drug abuse is sneaking up. That's one of our big problems. We did, one of the things that we did is through the Medicaid program, we require if you're prescribing or getting a prescription and you're on Medicaid, you have to have pre-authorization with the plans. As soon as we put that in, we saw almost a 50% reduction. Well, actually it stayed down, but the early one was even lower, but a significant decrease in the number of pills prescribed. And I think that at this point last year, we had seen a 52% decrease in what we were paying for from narcotics, but only a 12% decrease in prescriptions given. Since our Board of Medicine regulations went into effect this year, we've seen a decrease in the number of morphine milligram equivalents that are going out. I mean, there's been some pushback. The day they were signed, we heard of a new disease no one ever heard of, which is called an allergy to buprenorphine. It's amazing. And people are still getting prescriptions, but the numbers of pills are down. It seems to be working in terms of getting to the preventive part. Again, I put this up by way of saying the cause and effect, I haven't seen it. Another problem we recognize, those of you from Southwest will say, well, the judges, we had a meeting with them a year ago, and they said, well, we can't do medically assisted treatment. Why would we give them what they were breaking and entering to get? And that is Subutex or Suboxone, which people can't abuse. And that's a problem, particularly in the Southwest. So instead of trying to put in code limits on it, which leaves no nuance at all, we put in some regs. And so we've seen that product that we're worried about go down, and the buprenorphine, which is a combination product, which is much safer and non-abusable, is being used more. So it's not perfect, but those are the issues that we're seeing. And then we deal with the culture change, which I've already taken you through. Now, just a couple other things to get off of those topics. You all are generally interested in the Comprehensive Services Act or the Children's Services. This will impact you. You can see where our expenditures are, and what has happened over time is this piece here has gone up, and that basically is special ed services. It's things that arguably should be paid for in the education arena. And again, this is the wrong pocket problem we're having now, trying to solve this. But when you're sitting in House Appropriations and you're seeing this, you're saying, what the hell is going on here? And why is that? And that is driven almost entirely by private day schools. So when your schools say, we can't take them anymore, and you send them out to us, we've seen this kind of increase. And the challenge that we have is that you all write the EIPs, we pay the bill. There is no overlap, cost sharing, anything about that, and so we get a wrong pocket problem. And the General Assembly, we worked at it for a couple of years, couldn't get any consensus. The appropriators decided to assign it to their staff, and they're going to take a pass on it this year too. I saw the report yesterday. They can't figure it out because we haven't gotten this. Yes, sir.
But with that, there's an increase in diagnosis for the autism spectrum.
Yeah,
as well, though. I mean, you know, in the past, a child can be developmentally delayed, but at age 8, they lose that label. Mm-hmm. So now a lot of people are going to the autism spectrum, which is a very broad.
Yeah, it is, and that's driven a lot of that. There's no question. I wasn't getting back to the why, but I'm just saying if you're a state appropriator looking at the budget going up $20, $30 million a year, and you're saying we have a sum sufficient requirement, and they don't like that. And so the idea is, though, it's not just this, because there may be alternatives to just private day, and we don't even have the ability at CSA or in the community. Your social service and behavioral people aren't able to sit with the school people and say, the parent can bring an advocate in and say, you've got to send our kids to school in Idaho or in Hawaii or wherever, and then the neighbor's kid goes, and they've got the advocates. We can't come to the party and say, but we can do the same thing down the street. It still may need to be out of the school system, but there may be something that makes more sense. Yes, sir.
Yes, sir, Secretary. I'm on the CP&T, and I got.
Please call me Dr. Secretary. I've only got 2 months left.
I'm on the local CP&T, and this is a problem. And it's
Where
not,
are you?
Louisiana County. And it's not a left side out, right side out, conservative, liberal problem. This is a us problem in the state. And the problem that I see is we have a local autism school we run in our Louisiana County Public Schools, but we can't get any of your funding. So the local match on the state level on our part is 22%. So unless we can do it for less than 22 cents on the dollar, it doesn't make sense for us to do it. When we can save you money, everybody in this room money, if we just come together and do stuff that makes common sense. This is not difficult.
Where did I start today?
I get that.
Long problem, you know.
How do we fix it? Do we need to
Well,
have a whole
you know,
legislature?
we got to have smarter conversations, and we can't just reflexively say, no, this is my budget, and I could lose in this. At the end of the day, we're all responsible to the same people who are both the citizens we're serving and the taxpayers we're taking money from.
That's right.
And we tend to see our piece of it, but looking across the whole thing. And I mean, this is the 8 years. This is the, you know, my walk-up song when I finally make it to the Nationals. When I come up to hit the first time, they're going to play Toby Keith. I wish I didn't know now what I didn't know then. Yes, sir.
One of the experiences that we encounter is on the day service.
Who is we and where?
Pennsylvania County.
Well, you know, we've been complaining. You all send us people like Todd Haymore. We want to put up a wall, and you all are going to pay for it.
He's homegrown. We'll take him back. That's right.
That's an alternative.
One of the experiences that we saw, and I served on the same board last year, was we have multiple daycare providers, but they charge considerably different variables for the same service. Mm-hmm. And it seems like at the state level, maybe we could do a better job at controlling those costs, because we're not doing it at the local level. I mean, and the disparity is significant for the same service, even though they meet the parameters.
So, who here is from Fairfax? Anybody? They're not here. So, and I'm from Fairfax, so I can talk about us. The problem we'll have is that if we set the policy, and we've tried this with daycare, right, which is a big issue with daycare. Well, Fairfax will come in and say, but we already do all of this, and this is duplicate and extra work for us. And the challenge that you have at the state level is you all are different. I mean, and so having that discussion invariably creates some winners and losers, or the perceptions of that. So, you know, it's something that, you know, if I came back to the data sharing thing earlier, I got these 15 localities to sit down together, and I said, look, you can't do this 134 different ways. You know, you got to decide what you want and come. And where I see here, you know, the opportunity is in a group like this to sit down and work through and come with some potential solutions and work with us on them, because we can't cram them down. And you know, the kids are with you. When you all had that big settlement back, you know, my first year, you know, it was huge. And you know, what we basically said was that if we take the money from you in penalties, only people lose are the kids. So let's figure a way to upgrade your performance and work your way out of it. And I think you all have done that, but you've got the same problems we all do now, truthfully. I do want to talk to you about Kathy Pemberton's favorite topic. Kathy, I'd ask you to stand up, but so they all know who you are. You're from the league. But we've made a lot of progress on the eligibility systems, and that has been a nuisance for all of us. And when the ACA was passed, one of the things that happened is they said we had to change the way we calculated eligibility for Medicaid to something called MAGI, M-A-G-I, which is maximally adjusted gross income. And I don't like the term MAGI because it suggests it was wise, but it was. So we ended up, we had 1992 computer systems, and we had a very short window of time, like 9 months, to get this up and running. Congress has this sense of magic, that things can happen magically. Like they don't want to deal with the CHIP reauthorization until December, and they've got on the schedule for the week after, we'll have to send out the notices because Kim can't turn her systems on and off that quickly, nor can we. And so we've been through a lot, but at this point in time, we've got the ability to variety these eligibility all in one system. We've kind of converted over. It's not perfect by any stretch. And we actually, by turning over the old system, have reduced our monthly operating costs by about $2 million a piece. We are working, we are the Medicaid, these sort of tells where we are with it. Our turnaround time on applications is now lower than it was in 2010 when we started. And it should continue to get better as time goes. And the challenge, again, this is a part of a wrong pocket issue, getting everybody the same way. Each of you had your own ways of doing things. In order to have one system, we had to more or less standardize it, and that's been painful. Kathy, has it been painful?
Yes,
You know, she was
Dr.
6'3" when I met her.
I was 17 years old, yeah.
Yeah, that's right. So, but we're finally through that. So, all public assistance programs are on there, and a lot of money gets transferred through that system right now. So it's a real workhorse. We are looking at adapting a child welfare update. I mean, we now have an outdated system there that's going by the wayside, and our first step is to create a mobile app for your employees. Right now, you send your social workers out. And this is something we talk about workforce. Your local social workers might start after a 4-year degree at $29,000, and we send them out into the field to do the worst work imaginable, going into homes. This gets to data sharing. Carl, or one of the sheriffs, goes into a home. They may have some idea what's happening behind the door, but our social workers don't. We don't get all that information. If there's drugs going down, if there are arms and things like that, we're not going to, if we suspect it, they come help us. We've got to do better with the data sharing. You know, we are concerned about people's privacy, we are concerned about security, but we also are concerned about our workers. And we can't continue to send these folks, generally young women, in, because you know what happens? They quit. And we're seeing enormous problems with hiring and so forth, and we're looking at developing kind of a career path for social work that makes more sense. But one of their complaints that impacts us all is that they go out and they do the work, and then they got to come back to the office and enter it in, and then our system loses it. So we're really trying to get it so they aren't doing redundant work. And a lot of the kids coming out now are used to having, they want first class. They're used to the technology, and they know what the model says, and they show up, and anybody here from Russell? They show up in Russell, and it's not that way, or wherever, and they just, the turnover, who pays for all that? Yeah, so that's something we kind of have to think through, but we're working to get this thing in the budget. So those would be, I think, sort of the high points, or maybe the low points, if you will, of where we are, but I'm happy to do questions for as long as you all want. Yes, sir?
Just as you're ending your tenure here, what's your sense of...
I don't have any sense.
of just your medical opinion about the overall health of our society? It just seems like I've been in, the healing world for a long time, kind of natural healing, and it just seems like we talk so much more about addiction and obesity and kids spending 7 hours a day on electronic devices and 15 minutes a day outdoors. I don't know if that's exactly true, but that's one thing I heard. Do you have sort of a sense of the general arc of, are people happier or healthier, or not?
I think not. I think not. I was going to see if I could find, I don't know whether John could, if I have the right disc, I can show you some maps. But first of all, anything I say, each of you can say, well, that doesn't apply to me because we're different. And if you look at our maps across Virginia, we've done a couple of things. You look at the things that create health, right? And the first thing I will tell you is that health is different for all of us. When I took care of a 22-year-old with a torn meniscus, their goal was to play football that next year. If I take care of a 72-year-old woman with a torn meniscus, she wants to dance at her granddaughter's wedding 3 weeks from now. Okay, so the typical things that doctors think about in terms of health outcomes don't match with what people want, and I tell them constantly we have to change what we talk about into things that matter. So we created something, version 1 of what we call the Plan for Well-Being. I prefer the term well-being because health is sort of what you have, but it shouldn't define how you feel about your place in life, and which is really important. And I think our sense of well-being is down. In fact, Gallup, the reason I got this is about 4 years ago I was in Washington, a meeting with Gallup, and they go into a certain number of homes every night around the world, and they have created an index that they think looks at questions that contribute to people's sense of well-being. And if you look at the data in Africa, you could see it drop off, and then Arab Spring jumped in. I mean, it was predicted. And you could watch country by country where this sense of well-being was happening. And if you look at our national maps, I don't have a national well-being map. I do have in Virginia where we call the Health Opportunity Index, where we looked at those factors that go in. And there are a number of pieces, particularly around youth, that matter in terms of sense of well-being. But why I think we're down as a whole, it's not just obesity. I was fat before it was fashionable. I grew up as a fat kid. I lost my first 20 pounds when I was 13. And I've been on this yo-yo thing, but it's not just obesity, it's all the things that go on, and I think it's missing the mental health. If you look at the opioid map, can we get these put in, Kate? This should be the VG or VLG MA, if I could just get those first maps pulled up. We'll see, I'll show you something, but as we look at our politics, and we look at what I refer to as the recent unpleasantness in Charlottesville.
That's where I'm from.
I think it's people who are just feeling that life is, that they don't have the opportunities we used to have, or the perception. Now, there will be some who would say we never had those opportunities. And others feel the loss. It's the loss that matters. I remember hearing a financial guy talk years ago about, and this is how mental health impacts physical. He said, people don't live according to what they make today. They live according to, well, this was a few years ago, what they expect to get. And what I think we're seeing is that for some people, they feel like it's just that what used to be there is not there, and they treat this, they treat equality and opportunity as zero-sum game. And that's an issue. So this is I'm going to go do later at the next talk, but these are the drug overdose deaths from the Center for Disease Control 1999, and this is 2004. And I tell people that red is bad. That's not a political statement. It's a heat. 2009, and 2014. Now you tell me, how are we doing? This is the tip of the
Can you
iceberg.
do that again?
Yes, sir. I've done it before. I'll try it again. 1999. These are just the deaths. It's the tip of the iceberg. 2004.
This is all drugs?
This is yeah. Oh, I think this is opioids. It's opioids.
Oh, okay.
This is opioids.
Wow.
And this is Virginia, what I just showed you. I didn't put all of this in. Hang on here, I might have, no, I didn't, I left them off. But anyway, that map, if you go back to here, so all of you all are in politics, right? Does that look like anything to anybody? A political map of any type?
Looks like the rural areas.
It does, and why it looks like the rural areas is the large, but if you were to drill down on even the urban areas, you would see red and blue. Some of it's poverty, some of it's economic distress. Would anybody say this looks like the Trump Electoral Map? And I don't mean this to be a politically does it, and to a certain extent. And so why does that, I've heard this referred to as a map of despair, and what this may tell you about Trump's election is that whether you're Republican or Democrat, these people were voting for something else. They say what we're doing here isn't working for us anymore, folks. And there are things that are associated with addiction, mental health issues. This kind of gets to your question, and we've got studies. I don't have them up here, and I can't remember all the details. But when you look at the things that are making more likely to one, take a drug, and then more likely to misuse it, and less likely if you're using and there's no hope in your life, are you going to go off, or are you just going to keep taking the damn drug? And these are things that matter, and I think this is real. And I think these people voted for none of the above as much as anything else.
Are these good like the different regions, do they keep good statistics of who is having these issues? I mean, is that, you think that's trustworthy as a map?
Oh yeah, I'm sure it is. It's as good.
That's going right down to Appalachian.
Mm-hmm. Yeah, and we're seeing, it hits us here. And there's no doubt we have we have fairly regular meetings with counterparts and so forth. I mean, West Virginia is ground zero in this.
Yeah, and then you can see there where like the hurricanes hit there, and the Gulf Coast is bad, and then all of Florida, and then basically the whole.
And this is the issue. There's a real divide here. But I wouldn't want to just say it's rural areas and depressed areas, because when you see it in Fairfax and these kids who are living in McLean, and the kids are dying there too, because as part of it's just the traffic. Read Dreamland. Read that book. Yes, ma'am.
I haven't, you didn't mention marijuana.
I was hoping I could get a whole hour and a half without it.
Is that something that maybe has to be legal? How does it fit into all of this? There's not a real big discussion about marijuana use.
Well, there is a huge discussion going on right now about it. And a couple of things that I could say. There's a difference between there's legalization and there's decriminalization and there's what we have. And if you just look at the data, a couple things pop out. It appears, based on CDC, that people who jump into marijuana are 2 times more likely to have addiction issues later than those who don't. Now, it may not be that marijuana causes that as much as a reflection of what's behind it, I don't know. Or maybe when you decide in your mind that you go from legal to illegal, you've already crossed the, I don't know what that is. There's some evidence out of Colorado, I think, that suggests that there are fewer opioid deaths when marijuana is available. And what I don't know after a year or so of legalization, there have been a couple major conferences that we've sent staff to, and depending upon what room they're sitting in, they hear different things about its impact on health. What I will tell you, though, is that there aren't any medical studies because the U.S. hasn't allowed them, and we should. I mean, when you say it treats this and it treats that, it's largely anecdotal because the researchers haven't been able to get the drugs to test them, and we need to go through that. That's just the medical oil types of things. We do hear my Wyoming colleagues have had trouble with the Colorado legalization because kids get the brownies and things like that, and they show up in the ERs overdosing. Yeah, but my biggest fear is this. The reason we have this drug problem is at the time that the profession was deciding we were going to be more compassionate to treat pain, along came this company called Purdue Pharma with this magic pill that was advertised as being non-addictive when used for pain. They knew it wasn't true then. They pumped money into marketing right and left. Marketing that funded, I mean, the number of drug reps went up proportionally. They all showed up in my office saying, doctor, if you give it to your patients for pain, they won't, if it's not pleasurable, they won't get addicted. They knew it wasn't true then. And what I see in Maryland right now, do you know what the biggest battle over medical marijuana has been? Not enough minority contractors to grow it. It's been a business decision, not a health decision, and that bothers me. Until we get that right, I think we got trouble. Yes, ma'am.
I think what you said about despair and well-being is right on target. National Geographic has recently run an article on worldwide sense of well-being. It's not the wealthy countries necessarily that have more well-being. Some really poor areas have a sense of self and well-being that we don't have in this country.
But you know, you all are the leaders, and you all are at the community level, and promoting that you know, we're at a situation where we see things about people who, you know, about race and about ethnicity and all that, but the truth is, if you look medically, we all come from the same place. Our common humanity is there, and we need to be able to bring the groups together and have those conversations that the fellow was talking about earlier, because it's just not going well right now. Yes, sir.
I think that's our last question.
Okay.
Go ahead.
Most people above the age of 30 drink a beer or smoke a cigarette before they smoke pot. And if you're genetically inclined towards alcoholism or those kind of things, it just all kicks in.
And the problem with these things we have now is they're much more addictive and much deadlier, which is why we have to be more afraid of them.
You mentioned that nursing home room.
Yeah.
If they offer online poker and the NFL Network, I'll take it.
No. You're out of luck. Thank you. I'm sorry I held you over.